We're going to be talking about colorectal cancer. If you haven't watched the Quesmed one before, the format is that we do an SBA, you have a go, and we'll chat about the different answers and then try and do some teaching around that topic. So without further ado, our first SBA is a 64-year-old gentleman. He's presented to his GP feeling increasingly breathless, occasional heart palpitations, and this has been going on some time now. On further questioning, he states he's also been really tired and he's lost a stone in weight. His stool can sometimes contain a little bit more mucus than usual, but he hasn't seen any frank blood or melena. And on examination, you do note he looks rather slim. He has spoon-shaped nails and angular stomatitis, but his abdomen and his rectal exam are unremarkable. An FBC shows you a microcytic anemia and a fecal occult blood test is positive. What is the most likely diagnosis?
So the poll is up. We'll give you about 30 seconds to answer them. Last few seconds. Okay.
Okay, yeah, so actually that's really good. So it was indeed a right-sided colonic cancer. This is because he's got symptoms of an iron deficiency anemia. And if you combine this with the systemic features like the weight loss, this should ring alarm bells for a malignancy of some kind. Right-sided colonic cancers often present later and more insidiously than left-sided ones. So this sort of is alluded to with the occult bleeding and the anemia. Occasionally you do get a right-sided mass or some vague abdominal pain when you examine them, but sometimes it's unremarkable like this gentleman. The stool in the right-sided colon is semi-liquid, so unlike left-sided stools which are more solid, obstructed features are rarely a presenting feature for this side. By contrast, left-sided colonic cancers present earlier than right-sided ones as a whole. As the stool is more formed on this side, they can also present acutely as a bowel obstruction. It's about 60% of the etiologies of a large bowel obstruction. And usually left-sided colonic cancers are your classic fresh red rectal bleeding that they've seen, or they might describe tenesmus, which is a feeling of incomplete evacuation after defecating. And then you may get a mass in the left iliac fossa or on a rectal exam. So hemorrhoids was one of the other options. This typically presents with fresh red bleeding, but it's seen on the tissue paper on wiping or immediately dropping into the bowel after defecating. They're also quite painful, which is not what's described here, and it wouldn't explain the systemic features of weight loss. Usually you also get a history of constipation or straining that's caused the hemorrhoid in the first place, not the looser stools like he's described. Ulcerative colitis, so this typically presents with an increased frequency of the stools, as well as the increase in looseness. You may see blood mixed in with the stool, but with ulcerative colitis, you'd expect a much more marked increase in mucus than what's described in this particular case. You may also find nocturnal incontinence with IBD, and so you should always ask about this. And perianal disease is often absent on a rectal exam for UC, unlike Crohn's disease, which would be the other inflammatory bowel disorder. Finally, a fissure in ano. So anal fissures typically present with fresh red rectal bleeding, but usually, again, the history is constipation and straining, not looser ones. You may also find pruritus ani that comes along with it as a symptom they describe, and you may see a mucoepithelial defect on the rectal exam. Usually for fissures, it's in the midline posteriorly, and you may see small skin tags around. So the teaching point around this was trying to compare right-sided and left-sided colonic cancers. So just to sum it up, the right-sided colonic cancers often present later in this more insidious manner. You may get some abdominal pain, but it's often quite vague. And what you're looking for are the symptoms of anemia. You may or may not get a mass in the right iliac fossa, and it also will depend on how slender they are or not, in terms of whether or not you can feel it. By contrast, the left side, we talked about, it can present as an obstruction. So that would be profuse vomiting and absolute constipation, i.e. they can't pass wind as well. And they may also describe a change in their bowel habit or tenesmus, and you may find a mass on your PR or in the left iliac fossa. So in terms of how we screen for stuff in the UK, the NICE 2-week wait referral criteria for a colorectal cancer suspicion are if you are over 40 with unexplained weight loss and abdominal pain, or if you're over 50 with unexplained rectal bleeding, or over 60 with an iron deficiency anemia, a change in your bowel habit, or if you have a positive fecal occult blood test. So basically from that, you can take that the older they are, the more high risk they are for this. The NHS screening program also now includes a one-off flexible sigmoidoscopy for men and women at the age of 55, and this is to look for and remove polyps. But bear in mind that there will be a cohort of people who missed this because it wasn't introduced at that point. So not everybody has had this. So our next SBA is a 48-year-old lady this time. She's presented with tenesmus, blood in her stools, and weight loss. She's also waiting to be seen by gynecology, as she's found she's having postmenopausal vaginal bleeding. And on colonoscopy, there are 4 suspicious looking polyps in the ascending colon. What is the most likely diagnosis? So we're going to give you 30 seconds again.
Last 5 seconds. Okay.
Yeah, so most of you have picked up there's maybe something genetic going on there, so that's really good, but there seems to be a little bit of a split between the first two. So chatting through this, the correct answer was HNPCC, or hereditary non-polyposis colon cancer. It's also called Lynch syndrome, so you may find this in some other textbooks or online. This is due to an autosomal dominant mutation in DNA mismatch repair genes, and it's typically due to microsatellite instability. These patients do not have extensive colonic polyposis. That's the difference between it and FAP. So we'll come on to talk about that one in a second. And usually you find the lesions are right-sided, and this describes the ascending colon here. If you're going to diagnose HNPCC, it's quite specific. There's something called the Amsterdam criteria, which the patient has to meet. So broadly, this is that you have to have had at least 3 relatives with HNPCC-like tumors. One of them has to be a first-degree relative, and you have to have it in at least 2 successive generations and 1 diagnosis under the age of 50. So there's quite a lot to meet there. This particular syndrome, the reason why this is the correct answer, is associated with endometrial, ovarian, and gastric cancers. So here this lady has postmenopausal bleeding, which is a red flag symptom for endometrial cancer. So if you put this together with scanty colonic polyps, that's when you get A as the correct answer. So by contrast, FAP is also autosomal dominant, and it occurs in approximately 1 in 12,000. This is about 0.5% of all colon cancers, and it usually presents in adolescence, so she's the wrong age group as well. It involves the adenomatous polyposis coli gene, or APC gene, in over 90% of the cases, but be warned that up to 20% can be de novo mutations, so no prior family history, it's happened spontaneously in this person. But the features that would make you pick this as the correct answer is usually there's over 100 colonic polyps, they're everywhere. You can also get duodenal polyps in 90% and gastric fundal polyps in about 50%. So it's really throughout the whole colon. And the colorectal cancer risk is essentially 100%. This is why usually we undertake a prophylactic pan-proctocolectomy, as that's essentially the life-saving treatment. So Cowden disease, this is a disease of multiple hematomas, and it's associated with the P10 gene in about 85% of cases. It's quite rare, so it's 1 in about 200,000, and it's also autosomal dominant. So if you had to pick one on the genetics of colon cancer, usually it's a dominant mutation, but we're going to go through and summarize them in a second. You can also get macrocephaly or breast or thyroid carcinomas with Cowden disease. Peutz-Jeghers syndrome, this is characterized by multiple benign intestinal hematomas, and it's due to an autosomal dominant mutation on chromosome 19. The bit that would make you pick this syndrome is there are characteristic mucocutaneous hyperpigmentations, which are not described here. So as long as it's around the mouth or something that the question might describe, or you may see in a patient. The polyps are benign here, but they should be put under surveillance. And also the other bit rarer, but the way it can present is these polyps can present as an apex for intussusception. And finally, we have Gartner syndrome. So this is a variant of FAP, but here the patients have the features of FAP, but also desmoid tumors and mandibular and cranial osteomas. So that's quite a lot. It's a little bit complex, but I think to try and make it a bit more broken down, we have the summary here. So FAP at the top, the majority is the APC gene. It's autosomal dominant, and what you're going to see described is hundreds in the colon. There may also be duodenal or gastric fundal polyps. Gardner syndrome is the above, but also with desmoid tumors, osteomas, supernumerary teeth are another feature, and thyroid tumors. HMPCC, we've discussed this, it's due to mismatched repair genes, usually MLH1 or MSH2. But I wouldn't get too bogged down in the specific genes depending on your level, just be aware of the differences between them. There's usually much more scanty polyps. It's usually on the right hand side, so ascending colon, and you do have an increased risk of other cancers, and this is the one that you can also see described as Lynch syndrome. Peutz-Jeghers syndrome, again autosomal dominant, STK11 gene, and the presenting feature, or the bit that's a bit unique about this, is the mucocutaneous pigmentations. So moving on to our next SBA, we have a 67-year-old gentleman. He's been seen in follow-up clinic after a curative right hemicolectomy for a tumor of the ascending colon. What is the most appropriate tumor marker to request to monitor for disease recurrence?
Last few seconds. Okay.
Okay, yeah, so the majority of you have it right. So the answer was CEA, but we'll talk a little bit about this in more detail in a second. But broadly, this is a tumor antigen type marker for colorectal cancer. That's why it's the correct answer. But it should be noted that we don't use this for diagnosis. It's not specific enough. So for example, CEA may be raised in IBD as well. What it is really useful for is when you have confirmed a diagnosis to monitor the treatment efficacy, the disease burden, or the recurrence of a cancer. So that's what we want to check in this gentleman. Running through the other tumor markers mentioned here. So CA19-9, this is a tumor marker for pancreatic cancer. It's a monoclonal antibody type marker. AFP is a tumor marker for teratomas and hepatocellular carcinoma. This is an antigen type marker. CA15-3, this is a tumor marker for breast cancer, and it's a monoclonal antibody type marker again. And another monoclonal antibody type is CA125, and that's for ovarian cancer. I think when I was in medical school, I used to try and remember it like your ovaries are more likely to be functioning when you're 25, not 53. But I'm not sure if that's a little mean. So this is just to sum up that we use CEA as monitoring the disease burden, how our treatment's working, and the recurrence. Because if he's had a complete resection, so that gentleman had had a curative right hemicolectomy, then your CEA, if it was high in the beginning, maybe that's what made you suspicious of a colorectal cancer, it should return to normal. And if it doesn't, you've got to think about, have we either missed something here? So you could have a synchronous tumor somewhere else in the colon. So we can't use this as a screening tool. So every now and again, patients, I think particularly with the internet out there, I've been asked, like, have you checked this? Does this mean this? Or they hear it's high and they be aware they will go away and Google. So I think if you've got someone there and you're telling them the results, it's really important to tell them that this is non-specific if it's the first instance. We don't know what this means. We need to do some other tests. And I also, a phrase I quite like to say to patients, because I am aware that they have access, which is generally a good thing, to much more information than in previous years. I say, like, Google is a really good place for finding questions to come back and ask us. It tends to be a terrible place for finding answers, because if they put in headache and a few other things, they're going to get brain cancer and come back. So sometimes that can be a helpful phrase. And if you've got a follow-up appointment for them, then they can come with a list, a family member, whoever else they want, and you can have that discussion. So next we have a 74-year-old lady. She's undergoing a colonoscopy for 2 stone weight loss and anemia. She has a past medical history of 2 cesarean sections and recurrent diverticular disease. She also smokes 40 a day. The procedure is really difficult because she's got lots of adhesions, probably from her cesarean sections. Always ask about these because I think they're considered a more normal operation, and sometimes patients forget to mention them. But if you're about to open up a tummy, you want to know it's there, or if you're going to go inside with a scope. So the endoscopist terminates the procedure. He ends at the hepatic flexure. He said it's not safe to go on. He's already taken 5 biopsies from lower down the colon. What is the next most appropriate investigation for her?
Last 5 seconds. Okay.
Yeah, okay. So I think sometimes virtual colonoscopy has not really been heard of, so that's why I wanted to put this one in. So you're right, the correct answer was C, CT colonography. So CT colonography, this is because this lady has quite a lot of red flag features for colonic cancer. We talked a bit in the beginning of the lecture about what those might be, and so she really does need a full investigation. Actually, her symptoms, if we're remembering back to the first few slides, are more suspicious for a right-sided colon cancer, which we haven't reached yet because we had to stop at the hepatic flexures. We haven't seen all of it. This colonoscopy is therefore inadequate. So although we've got biopsies from lower down, if those are normal, it doesn't tell us there isn't something a bit higher up. So I threw in the diverticular disease. You can get benign diverticular strictures alongside carcinomatous ones. So you can't put her symptoms purely down to her diverticular disease without fully investigating. So when a colonoscopy has failed, our investigation of choice is CT colonography, as it's more accurate than some of the barium studies. Also, it has the advantage that it can detect any associated liver mets because it's a CT of the abdomen and pelvis. So moving on to that, a CT chest abdo-pelvis. She is going to need this potentially later. This is used though when we've confirmed a malignancy, and what we're trying to do is identify distant metastatic disease. So that's not the case here. Later on, this can help then to stage it. Repeat colonoscopy. So this would be inappropriate because we've already tried once, so there's no reason why this would work again a second time round. And that would really put the patient through an unnecessary additional invasive procedure, because I think we can all agree a colonoscopy is pretty horrible. Just the bowel prep is really unpleasant for patients. So a PET scan, again, this is a bit like a CT chest abdo-pelvis. It's used once we've confirmed a malignancy, and that's to identify the distant mets if there is any to find. Usually, though, you use a CT chest abdo-pelvis in the first instance, and then if you're still feeling that she's at risk of a met, or it didn't identify much but you're suspicious, a PET can help if there's uncertainty about nodal spread. So an MRI mesorectum, this is used in staging carcinomas of the rectum here. So she's seen, the rectum has been visualized, that seemed okay. And again, it's used once we've confirmed a malignancy. So this doesn't appear indicated at present. So talking a bit about the investigations for colon cancer, I think you always, in your head, try and structure things because it helps you to come up with answers, particularly if you're starting off as a third year, you get asked stuff on a ward round and your mind goes blank and you're going, oh gosh, and then you just kind of lob stuff out that's from a list. The way I like to structure investigations in my head personally, so this is more of an outpatient setting, so we just have two that I'll talk about in a second, but usually I think about tests that I can do at the bedside with the patient, so those would be things like your ABGs, your ECGs, etc. Bloods I take a little bit away from the patient because they have to go off to a lab, and then your specialist imaging, and I try and always kind of think in those categories. So in terms of a colon cancer, we want a full blood count because we want to see if there's any anemia there. If there is, then, and it's microcytic, then we're going to need to do hematinics to look at the ferritin level to see if it's iron deficiency or something else. You can look at their kidney function. That's also the first thing that your radiologist is going to ask for if you're trying to ask for a CT with contrast. You can exclude other pathology that might be giving her that tummy pain with using these LFTs. If any kind of liver met suspicion was there, the LFTs would help with that, and clotting is a function of a liver, so that's where it's useful. The specialist imaging, first step in the diagnosis of a colorectal cancer is a colonoscopy, because this allows direct visualization of the colon, biopsies, and removal of any polyps there and then of anything seen, and you can send those off to histopathology. We've talked about that if this fails, you can then try a CT colonography as a suitable alternative, but remember that this isn't going to allow you to biopsy anything. If you then do confirm a malignancy, this is when we consider staging CTs, PET scans, or if it's a rectal tumor, an MRI mesorectum. So our next case, we're going to talk a little bit more about management. So there's going to be 2 SBAs and then we'll have a chat about it. There's a 68-year-old lady, and she's presented with a 2-day history of absolute constipation. So she's not passing wind or stool, and she's vomiting a lot. When you examine her, she's tachycardic, but she's not got a temperature. Her abdomen does look very distended, however. A CT chest abdo-pelvis shows an obstructing rectal tumor. What is the most appropriate treatment option?
Last few seconds. Okay.
Okay. Yeah, so I think the tricky bit with colorectal cancer, or with colorectal surgery in general, can be all the different resections, because there's a lot and it can get a bit confusing. So this is why I've put these ones in. So the correct answer here was a loop colostomy. So this is because in the emergency setting, which is what we're in here, because she's got a bowel obstruction, resections of rectal cancers should be avoided. This is because you need to fully stage this rectal cancer. So we need that mesorectum MRI that we talked about, in addition to a CT chest abdo-pelvis. So in this emergency setting, the best thing and the safest thing to do for this patient is a simple loop colostomy, as if you tried to join anything, the risk of an anastomotic leak would be far too high. And then at a later date, when you've fully staged it, you can do either an anterior resection if it's a high rectal tumour, or an AP resection of the colon and rectum if it's a low rectal tumour. For your interest, rectal cancer resections require 2 centimetre margin. And for this particular one, the patient can also undergo neoadjuvant radiotherapy and chemotherapy. So talking through the other options, a low anterior resection and end colostomy. So this can be a treatment option in left-sided colonic cancer that presents with obstruction, but this lady has an incompletely staged rectal cancer, so it's not left-sided. It's lower down than the left side of the large bowel, and it's better to defunction the bowel and resect it at a later date once this has been carried out. So a pram-proctocolectomy, so this is taking out the whole of the large bowel. This is the surgical management usually for severe ulcerative colitis. And that's because in ulcerative colitis, it only affects the large colon. So if it is particularly severe for that patient, it's potentially curative. However, here, like we said, we have a rectal cancer, and it's better just to defunction the bowel. And also, should that staging reveal that it is still in situ and it's potentially curable, then she may actually need a far smaller resection than taking out her entire large bowel, so it makes it inappropriate. A left hemicolectomy. So this is a surgical treatment option in a descending colonic tumour, whereas this lady has a rectal tumour, like we talked about. Again, a bit like with option C, once it's staged, we may find actually she requires a much smaller resection than a full left hemicolectomy. So an AP resection of the colon and rectum. This is used for low rectal tumours, and I've got a whole other slide about this a little bit later on. But usually that's classified as less than 5 centimetres from the anal verge. And this wouldn't be carried out in the acute setting, so that we have time to stage it. And also with this one, it would be inappropriate when we don't know, because it's not going to leave the anal sphincter intact. So that's potentially really debilitating, and it may not be necessary. So our next SBA, also keeping on the management theme, we have a 63-year-old gentleman. He's found to have an adenocarcinoma of the transverse colon. He undergoes staging investigations which confirm he has no metastatic disease, and he's otherwise fit and well. After discussion at an MDT meeting, it's decided he would be for a curative resection. So what is the most appropriate surgical management for this gentleman?
Five more seconds. Okay.
Yeah, so the majority of you have that right. That's really good. So the correct answer is an extended right hemicolectomy. This is because he has a right-sided colonic cancer, and these can be treated and curative with a right hemicolectomy, and usually for these ones we actually do a primary anastomosis, even if they're obstructing, as the risk of an anastomotic leak for these people is low despite the emergency setting. So this is where it differs to a left-sided cancer. For cecal or the ascending colon tumours, just a simple right hemicolectomy is sufficient. But here, because it's in the transverse colon, we're going to have to do an extended right hemicolectomy, and that means it goes round to the splenic flexure. So, I mean, it makes sense then to talk about the right hemicolectomy. So again, we've talked about that it would be possible, but for her, we need that little bit extra taken out. So it's an extended, not this simple right hemicolectomy mentioned here. A pan-proctocolectomy, we've talked about a little bit in the last one. It's for ulcerative colitis, and her right-sided colonic tumour may require a much smaller resection again than this, so it's not the most appropriate option. An anterior resection with a loop ileostomy. So this is a surgical treatment for high rectal tumours, and so that's greater than 5 centimetres from the anal verge. It's not the correct resection for a transverse colonic tumour. An anterior resection carries the advantage of leaving a rectal sphincter intact if you do form an anastomosis, unlike the AP resections we talked about in the previous slides. But a loop ileostomy is usually performed initially and then reversed later to protect that anastomosis while it heals in the first few months. And finally, a left hemicolectomy and end colostomy. So this is one of the surgical treatment options when you've got a left-sided colonic malignancy, whereas her tumour is right-sided, so it's not the correct option. Broadly, your options for a left-sided cancer are going to be a left hemicolectomy with a primary anastomosis, a colonic stent insertion, or a subtotal colectomy and anastomosis. But this is where we're going to go through most of them, because I think there's a lot of them. And I think it can be helpful to draw diagrams such as this. So this is one that was found on Wikimedia Commons, but if you look on the internet, there's good detailed diagrams of which of the particular sections. Broadly though, for you, when you're on the wards, anything that is on the left-hand side is probably going to be a colostomy, and anything on the right-hand side is going to be an ileostomy. So broadly going through, AP resections are used for tumours less than 5 centimetres from the anal margin. This is when you remove the proximal sigmoid colon, rectum and anus using both abdominal and perineal incisions. And then the bowel end is exteriorized to form a permanent end colostomy. By contrast, your anterior resection is used for tumours more than 5 centimetres from the anal margin. And in this, you resect the tumour and form a primary anastomosis between the two ends of the bowel. A temporary loop ileostomy can be fashioned to allow healing of that distal anastomosis like we chatted about, and then later on you'll go back and reverse this. Left hemicolectomy is used for tumours of the splenic flexure, descending colon and the proximal sigmoid colon. A right hemicolectomy is used for tumours of the cecum, ascending colon and the hepatic flexure and the first part of that transverse colon. A sigmoid colectomy is indicated for tumours of the sigmoid colon, fairly obviously. The pan-proctocolectomy we have talked about it's usually an elective procedure, and it's in medically refractory ulcerative colitis. For this though, note your patient is going to have a permanent end ileostomy and they need to be counselled carefully about that. If you see the phrase Hartmann's procedure, because that's another very common one you'll see in people's notes, this is a sigmoid colectomy with the proximal colon exteriorized to form a temporary end colostomy. And then the distal bowel is oversewn as a rectal stump. So it's usually used in the emergency setting, a bowel obstruction, bowel ischemia, toxic megacolon, or a perforation. It leaves the option for things to be reversed later on down the line. But in reality, only about a third of patients do end up having it reversed. So it's just something to bear in mind. So now moving on a little bit to how we stage cancers. So this SBA is around a 27-year-old gentleman. He's got a strong family history of colonic cancer, and he's presented with a supraclavicular lump and clinical jaundice. He's found to have a colorectal adenocarcinoma with liver mets and a distant lymph node involvement. What is the correct Duke's classification?
Last 5 seconds. Okay.
Okay. So some of you have got this right. I think there are two main staging systems. I'm going to talk about both for colorectal system. There's Duke's and there's the TMN staging, which you may well have seen in other cancers as well. So this was Duke's stage D, and that's because he has a distant metastasis. So that makes him the furthest down the line in stage D or 4. To talk a bit about, because why we bother to stage people is because we're trying to get an idea of prognosis, or it can be helpful to give a prognosis, because that's a lot of patients' first question. So if you are Duke stage D, it has a prognosis of approximately 6% survival at 5 years if it's a non-resectable. If it's a resectable type tumour, you have a prognosis of 25%. So it's a little better, but we can agree it's not a good picture. If patient has stage E, they may present with features of their distant disease. So for example, if a gentleman has, or a lady has colonic cancer, but they have a liver metastasis, they could present with jaundice, which is what he's presented with, but he may also have hepatomegaly or even ascites. So running through the others then from the top, Duke stage A is when a colonic tumour is not is confined to beneath the muscularis propria, and it doesn't extend beyond this, and there's no nodal or distant metastasis. It has a really good prognosis, and that's about over 90% survival at 5 years. Duke stage B, so this is where the colonic tumour invades the muscularis propria, but with no nodal or metastatic disease again. This prognosis is a little bit lower. It's approximately 65% at 5 years. And then finally, C1 and C2. So Duke stage C broadly is where the colonic tumour invades the muscularis propria, and it has regional lymph nodes involved, but it doesn't have any distal metastasis. C1 disease is when you have the apical, i.e. the highest point of lymphatic drainage, is not involved. And it has a prognosis of about 40% survival at 5 years. By contrast, Duke stage C2 is where the apical, so that highest point of lymphatic drainage, is involved. And it drops the prognosis down to about 25% survival at 5 years. So just talking a bit through the two different staging systems. We've talked about Duke, so I'm not going to go over that again, but the T&M system, so T is tumour, N is nodes, and M is metastasis. So tumour is how far the tumour has grown through the bowel wall. So you can see that, I think that diagram is a really nice one for showing you that. So T1, the tumour is still in the inner layer of the bowel. T2, the tumour has grown into the muscle layer. T3, the tumour has grown into the outer lining of the bowel wall, and T4, the tumour has grown through the outer lining of the bowel wall. In terms of the N, N0 is that there are no lymph nodes containing cancer cells. N1 is that there are cancer cells in up to 3 nearby lymph nodes. N2 is cancer cells in 4 or more nearby lymph nodes. And metastasis, it's whether or not it's spread, so it's much simpler. M0 is the cancer hasn't spread to other parts of the body, and M1, the cancer has spread to other parts of the body, like the liver or the lungs. And again, your prognosis will worsen the further through that system you get. So next SBA, we have a 59-year-old gentleman. He's referred under the 2-week wait rules for a change in bowel habit and blood in his stools. His past medical history is fairly unremarkable. He undergoes a scope and a scan, and he's found to have a cancer of the ascending colon and a single 3-centimetre peripheral liver metastasis. What's the most appropriate management for this gentleman?
Give me 1 moment, I'll get it back up.
Thanks.
Okay, you should be able to vote now. Sorry, I'm just going to try it again.
That's okay.
Okay, you should be able to see them. As in, people should be able to vote, but I don't think it's going through for some reason. Aha, we've got some. Okay, sorry about that, but I think it's working now. We'll give you a few more seconds. Any last votes? Okay.
Okay, so there's a bit of a mixed picture there. The correct answer was B. So you want to resect both the colon cancer and the liver met. And so this is because colonic cancer, if it has a liver met, is actually still potentially curable, which is a really good thing. I mean, not good if they've got a met, but it's something positive you can say. If you resect both the cancer and the liver met, your 5-year survival rate is going to increase from 5% to 25%. So it's not a great prognosis, but it is a significant improvement. Sometimes we give chemo prior to the resection. He is young and fit enough to undergo surgery. He's got no real past medical history, and he should be given the best possible chance of survival by resecting both of them. In terms of the other options, radiotherapy, there's no role for radiotherapy in this. It doesn't improve the outcomes. A colonic stent is used as a palliative surgical treatment option for symptom control, or if you've got an obstruction from an incurable malignancy. Colonic cancer with a single liver met like him is still potentially curable, and so we need to resect it surgically. Palliative chemotherapy, again, as this is still a potentially curable cancer, we should give him the best possible chance of survival, and he's not for palliative care here. And finally, surgical resection of the colonic cancer and radiofrequency ablation of the liver met. So radiofrequency ablation is useful when the patient is not fit enough to undergo surgery. So this patient is young for medical terms and has no prior past medical history. It sounds like he's fairly fit and well. So that's what makes this not the correct option, is that we should be giving him actually the best possible chance and not treating him as a patient who's not fit for surgical options. This is because although it's good, radiofrequency ablation has better outcomes than not intervening at all, but not as effective as surgical resection. So that's why we should go for that. And that's because this is a solitary met. So that's quite a lot in one session. I realize that it will be a mixed picture of different years at medical school, but if you remember nothing else, then this is a kind of rough summary, is that your management is going to depend a lot on tumor factors. So that's the staging and the location, as well as the patient. And that's what goes into decision making. And that's where MDTs are great, because you get input from lots of different clinical and non-clinical staff members. So what I would encourage you to do if you are on the wards and stuff, and I certainly do it with my registrars and consultants, is when they've made a decision about a patient, or if you attend an MDT, sometimes I know it's a little bit scary, you can't always like interrupt in the thing, but you can ask afterwards, like, what was your reasoning behind that decision process that this person went for that? Or, you know, I've done a bit of reading, I think I would have assumed it was this, but you went for that. And they might say, oh, well, actually this patient isn't that fit, or he requested this, or he had this at home. And it'll start to help you begin to think of those nuances that actually is what we see in our seniors as independent decision makers. So broadly though, in cancer that has not spread, you're going to do surgery and you might do chemotherapy afterwards. If it's spread to lymph nodes, then you will definitely need post-op chemo. And if you have distant mets, then sometimes you have preoperative chemotherapy, surgery, and post-operative chemotherapy. Or we've talked a little bit about if it's a completely incurable and distant metastatic spread and the symptom is an obstruction, that's when you might place a stent or something like that. Most patients for rectal cancers, you have if it's essentially where it is in the canal. So if you have tumors more than 5 centimeters in the anal canal, or if it's involving the proximal third of the rectum, this is the one for your anterior resection. And if it's less than 5 centimeters or in the distal 2/3 of the rectum, that's your AP resection. If you have stage 3 disease in this, patients will benefit from a post-op chemotherapy. And if you have stage 4 disease, then you benefit from both chemo and radiotherapy post-operatively. If you think your patient is unsuitable for surgical management, then chemotherapy for these tumors, I won't go into all the different names because I think that is beyond what you need to know, but I think remembering that you're going to have to take into account an anaesthetist point of view as well as to what's safe to proceed is also a good thing to bear in mind. And this is obviously all with discussions with the patient and the family. And you may have added other things you have to consider, like if they have Alzheimer's or aren't able to consent because they don't have capacity. So we're coming to the end. So just then talking about the bits that happen after surgery. And I think if you do have a colorectal surgery replacement or an emergency one, watch a stoma being formed, because it's so much easier to examine a stoma when you know what went into putting it there. You can understand more what you're looking at. I certainly found that helped me. And if you seem keen and interested and you say that's because I want to have a look at it, and then people are usually very happy to let you watch stuff like that. So here we have a 51-year-old gentleman. He's presented with pain around his stoma. He's recently undergone a loop ileostomy. And when you look at him, there's blistering and there's erythema around that stomal opening, and the bowel is lying flat with the skin. What is the most likely complication that has occurred?
Last 5 seconds. Okay.
Yeah, so majority of you guys have got it right. So to talk through why. So a loop ileostomy is when you deliberately spout a bit of bowel afterwards. So that's because an ileostomy's output is hugely irritating to the skin. And in this particular question, it describes the bowel as lying flat to the skin, which it shouldn't be. So this means that the ileostomy continents have been able to come into contact with the skin, and that's what's excoriated it. In the case of retraction, you need to look at the terminal bit of bowel really, really carefully, as this can be secondary to necrosis, and that's why it's contracted down. And actually a good tip someone taught me for looking at that, if you're looking at the end and you're not quite sure if things are necrotic or if they might be further in, you can take one of those blood bottles that you usually do your venipuncture with. If you take off the cap, what you've got is a clear tube. So you can put that into the stoma and you can have a look and see if it looks pink further in. Obviously, for goodness sake, don't let go of the tube. But it can be a useful way of looking in with a light to see stuff a little clearer. So in terms of the other options, and these are all sort of stomal complications, and that we'll run through them, but I would say also on your placements, there's usually a stoma nurse that goes around and helps with them, and she or he will be a great source of information in terms of asking them what helps go into the planning of where you're going to site a stoma, because that's really important. What factors were important to that patient, what's made her decision as to where they've ended up putting it, and what does she look for. So when you examine a stoma, you should be looking, is it pink, is it healthy, is it spouted like it should be, or is it spouted like it shouldn't be? So colostomies are flush with the skin, ileostomies are the spouted ones. And looking for any signs of necrosis or pain or bleeding around it. So stomal stenosis, this is where the stomal opening has become smaller, and it can present with like a ribbon-like stool, or sometimes a very high-pitched wind can be the other symptoms you get with it. It can be secondary to ischemia, and this is one of the ones that requires surgical correction. What they tend to do, so if you ever do see a stoma brought through with the skin, they tend to, just before the operation's finished and the patient is woken up, a finger is just placed on the inside to check that it's not too tight, so we're not going to get this. A paracolostomy hernia. So this is where your peritoneal contents herniate through the part of the abdominal wall that was incised in order to place the stoma in the first place. You'll essentially get a bulge that's adjacent to the stoma, and it's usually a bit of a later complication. Initially, you can treat it conservatively. The key things that you'd want to check is that there's no features of obstruction, and that it is soft and reducible, not incarcerated. So a stomal prolapse. This is when the colon comes out into the stomal. The colon comes out into the stoma bag. So it doesn't present with an opening flush with the skin, which is what's described here. This one also requires surgical correction. And if it's really a lot of bowel contents, then cover it with a wet cloth, and you need to look for electrolyte imbalance and stuff like that. Stomal bleeding. So some degree of bleeding in between stomal bag changes is common. But what you need to make sure is that it's not luminal bleeding, as this is what can be pathological. So for example, this could be a sign that you're having another flare-up of an inflammatory bowel disease. Sometimes you can see dilated veins around the site, but in some patients this can be secondary to portal hypertension if you've got a prior history of liver disease. So it's not that specific a sign, but it's something to look out for. So that moves us on to our last slide. We've talked about the stomal complications that are, I guess, more surgical, but also please don't underestimate the psychological complication of a stoma, particularly if it is a Crohn's or an IBD patient. They typically can be very young, and a stoma is going to be a life-changing thing for them, particularly if it's a permanent one. And really counselling your patient and keeping in mind autonomy is also something to really be aware of, and actually talk to your seniors about. There's cases where actually you'll be in a resection that they're doing a primary anastomosis, and it was actually the riskier option, but they chatted with the patient and they counselled them and they explained all the risks of doing a primary anastomosis in terms of a leak, but the patient was fully against the stoma, and if they have capacity, then it's patient autonomy. But it's just bearing in mind, I think, it also is in the process of being destigmatized somewhat, but if you're someone who's young and you want to be on a beach, you'll have your stomach exposed, it is different. If you have any friends who have them, there may be ways you can be helpful to them, even if it's little things like if you have a really high output bag, it may be that they're trying to change the bags quite a lot. So if you're out and about with someone who has a stoma and this is a problem for them, and they might not want to tell people, if they say something like, I need the loo, and everyone else goes, oh, can you hold it? You can just be that person who says, no, we need to find one now, and just help them out in that way, and not make them have to reveal why this is actually a thing that needs to happen right now. So that's the conclusion in terms of the SBAs and the teaching part, but I think we have time for questions now. I'm just going to stop sharing my screen. And there's more information about this on the Quesmed site.
Thank you so much. That's we'll move on to some questions. I've just put the feedback form in the chat because I'm aware some people might need to dash off after an hour. But if anyone, I know we've got a few questions in the Q&A that we can move on for. And the link, yeah, so the link to the feedback form is in the chat for everyone. Hopefully you can access it. Let me know if you've got any issues. And cool. Are you able to see the questions, or would you prefer me to read them out? I can do
quickly.
Okay.
1 second. Okay, so it was a 40% survival in C1. A loop colostomy is different to a Hartmann's. So a Hartmann's, what you're going to do is you're going to take out the sigmoid colon, so that's the sigmoidectomy bit, and then you're going to come out with an end colostomy. So a loop is where you, if you've got a bit of bowel, you're making a cut and you're bringing that to end, so you'll see 2 lumens. That's how you know it's a loop. Whereas an end is when you just have 1 lumen. So later on, you can take the end bit back and try and anastomose it if there's a reversal of the Hartmann's. But a loop colostomy is where you're going to take a small bit and bring it out with 2 lumens. So it's just that little bit different. Any more questions?
We'll give it one moment just in case there's anyone who wants to ask anything. And if you haven't already, if you could fill out the feedback form, that would be really helpful. Otherwise, if not, then thank you so much. That's been a really, really good talk, actually. It's been really good having the cases and all the explanations for all the answers to the SBAs. I'm sure everyone else found it as useful as I did, so thank you so much. I'll end the recording and it should be up at the end of this week. We usually upload over the weekend, so if you want to look over any of this again, it should be on the Study Hub website for you.